This is the 19th webinar that Pallium is hosting on topics relevant to healthcare teams who are actively leading the response to COVID-19. These webinars are made possible thanks to an unrestricted contribution from Bhéreur Ingelheim and their Bridging Hope initiatives, and we thank them for that. Today's webinar is entitled Clinical Protocols, What Real Cases Have Taught Us. So our panelists will be sharing their experiences caring for patients with COVID and comparing these experiences and sharing some of the emerging insights using the current COVID symptom protocols. Leading today's discussion are several subject matter experts who will be introducing themselves a little later on, and each will be taking us through a series of slides and engaging in dialogue. Next slide, please. I want to take just a few moments to talk a little bit about the palliative care exchange. The overwhelming response that we've received from healthcare professionals to these webinars has prompted a really exciting partnership between Pallium and the Canadian Society of Palliative Care Physicians. And with support that we've received from the Canadian Medical Association, Scotiabank, and MD Financial Management, the Canadian Society of Palliative Care Physicians and Pallium have launched a moderated online community of practice, what we're calling the Canadian Palliative Care Exchange. And the exchange supports interactive, ongoing national dialogue between healthcare professionals from right across the country regarding the most relevant COVID-related topics in palliative care. The exchange is a professional learning site, if you will, and it's moderated by members of the Canadian Society of Palliative Care Physicians, and it's open to all healthcare professionals, including physicians, nurses, social workers, pharmacists. There's no cost to participate. So I really encourage you to join the exchange to ask questions about palliative care during the COVID pandemic, sharing your experiences, teaching and learning with other healthcare professionals from right across the country. Visit cpcexchange.ca to take advantage of this. On to some housekeeping. In terms of housekeeping, your microphones have all been muted. It doesn't mean that we don't want to hear from you though. So we'd like to solicit your input and questions throughout the webinar, which you can do by using the Q&A function at the bottom of your screen. And throughout the webinar, our panelists will be answering questions that are raised, and our moderator, Dr. Marshall, will be bringing some of these forward to the panel for further discussion. So I do encourage all of you to ask your question, post your comments. It really adds to the collective knowledge that's going to be generated over the next 60 minutes. So thank you in advance for doing so. We also want to remind everyone to respect privacy and confidentiality, and that you refrain from sharing any specific details on cases or particular situations when posting your questions and comments, and we appreciate that. We will be collecting and collating all for future reference. The session is being recorded and it will be available on the Pallium website in about 24 hours. Next slide. Okay, so I'm your host for today's webinar. My name is Jeff Moat. I am the Chief Executive Officer of Pallium Canada, and I'm going to let each of the presenters introduce themselves, and we'll start first with today's moderator, Dr. Denise Marshall. Denise, over to you.
Thanks very much, Jeff. It's just my pleasure to be moderating this panel today on behalf of Pallium Canada and its Scientific Director, Dr. Jose Bhéreur. And I have the pleasure of introducing our two speakers today. I think affectionately during the planning of this webinar, they became known as Ann B, Dr. Ann B, and Dr. Ann BH. So let me proceed by introducing Dr. Ann Bhéreur. Dr. Ann Bhéreur is an associate clinical professor of the Department of Family Medicine and Emergency Medicine of the Université de Montréal in Quebec, Canada. She has a practice and teaches palliative care and family medicine and has done that since 2003 in Hôpital du Sacré-Cœur, now part of CIUS, de Nord de l'Île de Montréal, and chairs the palliative care teaching committee as well for the family medicine program in her department. And so welcome, Dr. Ann BH. And Dr. Ann Boyle is a colleague of mine at McMaster. She's an associate clinical professor and enhanced skills program director in the Division of Palliative Care in our Department of Family Medicine at McMaster University, Hamilton, Ontario, Canada. She's also president-elect of the Canadian Society of Palliative Care Physicians, and Ann is a member of the Department of Medicine's Executive Committee and co-medical director of palliative care at St. Joseph's Healthcare in Hamilton, Ontario, Canada. So I think we're delighted to have these two eminent speakers. And my understanding is that we are going to be having a collaborative dialogue The ANDs will be presenting cases and using some of their new COVID created tools, but with the spirit of everybody on this call sharing and collaborating and exploring what's emerged from them. I see 179 participants, so that means we could have a rich dialogue. The ANDs are agreeing to be content experts, knowing full well we'll all be crafting new ways forward together nationally. So next slide.
Yes, I'll just mention very briefly declaration of conflicts. So for starters, Pallium is a national nonprofit organization. We were founded back in 2000. We're based in Ottawa and we're funded in part by Health Canada. Pallium equips healthcare professionals, healthcare organizations, communities with the skills and knowledge to provide palliative care earlier, more effectively, and more compassionately to all Canadians. In terms of conflict, I'm an employee of Pallium Canada, and I don't believe any of the presenters have any conflicts to declare. So with that, I'll pass the floor back to you, Denise.
Thanks so much. Like many of the people calling in today and our two ANDs, I as well am a palliative care clinician, professor in palliative care at McMaster University, and a medical director of two programs in Niagara area of Ontario, Canada. So I myself am very interested in what our participants will be saying. We can go on to the next slide. The learning objectives for today are stated here. We hope that upon completing this webinar, our participants will be able to review the guidelines used by the panelists and be contained in the slide deck that you'll be receiving, recognize how the guidelines they're referring to relate to the specific cases they've discussed with us today, and understand how the panelists learn from their experience dealing with COVID-19. And additionally, to be conscious of the technical issues that relate to using protocols that have emerged very quickly during this pandemic. On to the next slide. So with that in mind, then I'm going to pass over to our first speaker, Dr. Ann B., to present her cases to us. I should just mention to folks, though, before we do this, Anne, that we are going to do a question and answer at the end, and that's going to be a big part of this webinar. So about 10 to 15 minutes for each of the Anns to speak, leaving lots of time in the Q&A so people can put their questions in the Q&A function of the Zoom dialogue at the bottom, please, as we go. Over to you, Ann B.
Thank you, Denise. I decided that since AB and AB were presenting, I would call my cases Case A and Case B. So Case A is a 78-year-old patient who we saw from a retirement home here in Hamilton. They had a background history of vascular disease, aortic aneurysm, cognitive impairment, and had a MOCA of 18/30 about 4 years previously. They presented to the emergency room with generalized weakness, had a history of increased falls the previous month, and had a non-productive cough with fever for 24 hours. There was a known COVID outbreak at that particular home, and we had a number of patients who had actually come in from that retirement home. They were COVID positive on admission, were admitted to our COVID unit, treated with IV antibiotics and fluids. But unfortunately, this patient continued to deteriorate. Their oral intake was very poor, and after a week, they actually had their swallowing downgraded. At day 8, they were requiring a mechanical lift up to the wheelchair, and despite that surprising medical history, the patient was actually, according to the family, driving prior to admission. On day 9, they had new fever, and no other source was found except for a worsening chest X-ray. Infectious disease recommended that we treat them as a HAP at that point in time, and they continued despite new IV antibiotics to have ongoing DSATs and increased oxygen requirements. By day 10, the nurses were reporting that they were having to suction oral meds from the mouth. The patient was made NPO. They were becoming increasingly agitated, but as usual, their blood work was actually looking much better. By day 12, they were becoming more confused and intermittently more lethargic. SLP had said their swallowing remained non-functional. Can you go forward, please? On day 13, the family decided they were going to move from medical management to comfort-focused care, and palliative care at that point was then consulted. And the reason for referral was assistance with withdrawal of life-prolonging interventions. Now, when we met this patient, they were actually in 4-point restraints in order to keep oxygens and lines and Foleys and everything in, based on the family's wishes at that point. And they also were able, interestingly though, to answer some questions for me. So while they weren't actually oriented to place or date, when I said, "You're in a hospital, do you know why you're here?" He said, "I'm very sick and I'm not getting better, and that's no good." So there was this surprising sort of full sentence answer that I was not expecting from this person who was only uttering 1 or 2 words up to that point. And then when I asked about a priest, the answer was, "No way, priests are for sick people." So the family had said that religion was very important to the patient. The patient wasn't feeling quite so much that way at that time. They had evidence of multiple wounds from their multiple falls with dressings. They were febrile at the time, very dyspneic, and myoclonic despite not being on opioids. Pre-admission, they had had 1 Tylenol 3 a day. At the time we saw them, the only meds they had on board were apixaban and melatonin, which they hadn't been receiving because of their NPO status, and the antibiotics had actually finished that morning. We actually just added PRN medications because I had no idea what this patient was going to need, and we ordered really good oral care. The most important intervention I think we did for this patient, though, is we filled out their footprints form. And footprints is just a form that we use at our hospital about how to get to know your patients better, so that we learn about the patients with the disease rather than just the disease the patient has. And this was really important in COVID because everything was so focused on the illness that people had that sometimes the person who had the illness was being forgotten. And we found out that this guy loved jokes, 50s music, and red wine. It had to be homemade. And that they had been an immigrant, but had always was very proud of their Canadian heritage. So we ordered meds, turned on Oldies 1150, and got the patient a bottle of red wine so that they could dip the oral swabs in wine rather than just water, and hung a Canadian flag in the room. It turned out the next morning that the patient was actually quite calm, out of restraints, and it needed very little medication, a total of 2.5 milligrams of midazolam in total, and just 2 doses of hydromorphone. But the nurses noted that if the medication started to wear off at all, the patient became very agitated and very dyspneic quite quickly. Next slide, please. So we were actually developed here at McMaster under Dr. Pereira's guidance some symptom management protocols. The dyspnea protocol, which it mentions at the beginning, I'll show you later. Upper airway secretions were not an issue, nor was cough. Fever, we were using PR-acetaminophen. Delirium and agitation, we actually used doses lower than what's recommended here in the slide because this patient was quite frail elderly. And nausea and vomiting also wasn't an issue, and we had left PRN hydromorphone for their pain. Next slide, please. And we're doing good mouth care with red wine rather than just artificial saliva. What happened with this patient was they actually lived for over a month, and COVID remained positive. Their NPS swab, they had re-swabbed them later because the patient was stable, but their COVID swab did remain positive. However, the patient ended up needing very, very little in the way of medication, stayed unrestrained the entire time. It became a competition between the nurses about who could get the patient to laugh the best with the joke that they could tell. So the jokes became a really important part of their life. And the nurses became really engaged in caring about patients again because they saw how important something as simple as a wine swab of red wine changed this person and took them from restrained, with a little bit of good medication and palliative care, took them from restrained to happy. The second case, case B, is a 64-year-old patient who came in from home. They were the primary caregiver for their cognitively impaired spouse. The spouse had actually been previously admitted to the same hospital, to our hospital, when the patient came in. They had a background of quite severe COPD. They were using a significant dose of home morphine and had been on this home dose for quite a period of time, as well as some PRN Tylenol 3s for chronic back pain, because they personally believed that the Tylenol 3s worked better for their back pain than anything, and didn't use it all the time. They had also presented with fevers, very severe dyspnea, weakness, hypoxia, and were found to be COVID-19 in the emerge. Their goals were very clear, though: no intensive care interventions and definitely no BiPAP. They had previous experience with BiPAP and were unwilling to go back on BiPAP, which was also an issue around BiPAP and recommendations at the time with COVID patients. They were good for medical management, though. There was many things. She needed to know her husband was safe, needed to know her husband was cared for, wanted active medical management. But a profoundly frail cachectic patient weighing less than 100 pounds. They were actually on high flow, high humidity oxygen and needed 100% non-rebreather at times in order to maintain SATs. Started out initially in the emerge, they gave a 25% increase to their base dose, spread out over time. But when we saw in the, because of renal impairment, we had switched over to hydromorphone. Next slide, please. They did require quite rapid titration of medications, though, because of symptoms. Initially, we started out with Midaz every 4 hours, but again, on the COVID ward, we tried to quickly convert to an infusion to avoid the nurses having to go into the room so often. When we got this patient stabilized, we had them actually up to hydromorphone 7 milligrams an hour and Midaz 5 milligrams an hour. And we always tried to use the lowest dose because it was very important for this patient to still be able to window visit with her husband. The husband would be wheeled over and allowed to window visit. And their philosophy was, I may not, the spouse may not know me, but I know them, and it's important for me to see them. We did have trouble maintaining IV sites, didn't want to pick, and sub-Q sites because of the cachexia were quite challenging. We also had issues maintaining good symptom control because of line length, trying to keep the pump outside the room and the patient inside the room. These were early days. Everybody was scared, and there was new learnings coming out about COVID all the time. Next slide, please. They did complete their course of antibiotics, felt better, awake, alert, conversant, despite these ridiculously high doses of medications, and really was comfortable, but had decided, since they knew their partner was fine, if they did deteriorate and get worse, they only wanted comfort-focused care and were not willing to have ongoing active medical management, and ended up dying quite suddenly and unexpectedly 2.5 weeks into their admission. So if we look at our dyspnea protocol that we had developed here, we moved to the right side in that it is for patients who are already on opioids. We did follow through, but we actually needed to increase the medication even more quickly than an hour. We were actually initially doing kind of Q30-minute titrations, but this patient was maintained their cognition throughout all of this. Next slide, please. Again, I think what I've learned from these cases is a couple of really important things, is that the emotional prescriptions that we provide are equally as important as the pharmacological prescriptions that we prescribe, and that human illness is, and the response that humans have to human illness is consistent over time, and it doesn't change because of a pandemic. And people actually need compassion and care, and they need time and a kind word and a gentle touch, and they need to know they're not alone. And we can't forget that when we're in the midst of these crazy diseases. We learned that tubing length is an issue. If you have tube that's over a standard length, you have to have certain flow rates in order to guarantee medication delivery. So while we thought we were doing the right thing creating these long tubes, we realized that it might not have been our best plan unless we had solid intravenous access where we could maintain a rate that would guarantee our flow. The other thing is, with the very long tubes, we had to prime these tubes, and there was concern about us running out of medication, because for our hospital, they require all infusions to be prepared under the hood, the sterile hood. So our hydromorphone and our midazolam were only available to us if we had pharmacy preparing for us, and hood time was definitely an issue. We also realized that if we had a number of patients who required this medication, there was no way that there was going to be able to meet the needs of patients if we stuck with this strict need for having to have meds prepared under the hood. In retrospect, from what's come out now around medications, I'd probably have given these patients dexamethasone early based on some of the newer literature that's coming out around steroid use. I think some of the other things it's taught us is that usual doses actually do work. I think people thought that we were going to need massive doses, but in frail elderly patients, following good principles of palliative care and titrating to effect and side effect is effective. I think we learned it takes a village to make a doctor do their work, but also to care for a patient, and that you know, everybody from the CEO and administrators to the housekeepers, allied health, nurses, physicians had to work together and communicate in order to provide care. The AGO is not the Art Gallery of Ontario. It's just what we seem to be having multiple times through COVID, which is another growth opportunity. And it's kind of what it feels like when life teaches us roughly, which is what COVID has done to us. And I think that while we've all gone through and made jokes and shared funny cartoons and done these things, it really belies the stress that we've all experienced, having to face our own mortality, having to recognize what it's like to start filling out our own wills and our own powers of attorney. And when we, you know, often tell patients, you know, hope for the best, but prepare for the worst, or hope for the best, but stay prepared, all of a sudden, we didn't just have to look the worst in the eye. We had to imagine, okay, this is what the worst is going to be. How are we going to prepare for it? And while services like medicine and emergency medicine were making backup rosters of who was going to fill in for them, we quickly realized that, wow, if the palliative care physicians go down, there are not a lot of clinicians trained to be our backup team. We're stretched thin on the ground at the get-go. I think a lot of us faced not only our own mortality, but the fear of what if we bring this home to the family or the people that we actually love and care for. And we had to face loss of control at both home and at work, and loss of team and friends and family and social gatherings and childcare, and sometimes jobs, sometimes people's research had to be, you know, put on hold or life's work derailed. And I think it really made us stop and experience what it's like for patients who experience serious illness, and what it's like for our patients who have cancer diagnosis and CHF and end-stage COPD. But I also think it has provided us with this rare opportunity to take a look and figure out, I know the Democrats are stealing my line and talking about building back better, but I love this idea of what are we learning from this pandemic so that we can build back better? And what are the things that we have learned that can deepen our empathy and improve our healthcare systems and change our practice habits? And going back to that, you know, I said it's not R2D2, it's C2T2, compassion, care, taking time and touching. Like, we have to remember that we have to let go of the things we can't control and control the things we can, and realize that done is better than perfect during a pandemic, and we have to adjust to that reality. I think also we've recognized through this that we're in it for the long haul, and we don't even know what the long haul is going to be. But how can we practice more compassionately and more fully so that our work going forward actually feels right? Because it isn't just about protocols, because it's compassion that really feeds our souls and makes us realize why we're drawn to medicine in the first place. And it's really what gives us the strength, the energy, and the courage to go forward and face what we're going to face in this pandemic. And that's all I have to say, and I'm going to turn it over to the other Anne.
Thank you very much, Anne. I'm going to encourage our participants to put any questions they might have for Anne Boyle in the Q&A so I can track them while Dr. Anne BH is speaking. So please do that. And Boyle, before we move on, is the best way to get those 2 protocols that we saw there on the Division of Palliative Care's website, or do you have a better link?
We can either do that, Denise, or I believe if there's a way of Pallium sharing resources post, we can do it through that, whatever mechanism.
Sure, we'll sort that.
Yep.
All right, now I'm going to turn it over for a stellar 15 minutes for Dr. Ann BH. Over to you, Ann BH.
Okay then. So I'm going to go with a bit of a context at first, but I'll go through that quite fast because this is not the main subject of interest. So you can go next. So I do work in Montreal, northern part of Montreal. CIUS, that which we've seen earlier, is some Integrated University Health and Social Service Center. If you go next, we're going to see that it means 3 hospitals, 2 psychiatric centers, 6 local community service centers, and 11 long-term care facilities. So that means very, very big centers, where I've been working for a few years now since everything has been united. So you can go next. The pandemic, unfortunately, hit us very, very hard right at the beginning. On the 22nd of March, it started at us at Notre-Dame-de-Merci. I was there that day, and it started to be crazy. And it has since then. Now things are cooling off. But just to give you an idea, the short-term care, the short-term hospitalization, the numbers are too incomplete to give, but there was not as many people hospitalized in short-term settings. But the long-term care facilities that we have into the CIUS, we had at least 918 cases of confirmed cases, from which 564 had healed as of June 2020. More of them have healed since then, but I don't have the last statistics. And in June, we had already 354 deaths, which is quite a lot and was quite a burden on the situation. So you can go next. Next slide. I'm just going to start with mine. So the team we have 1 palliative medicine fellow. We're 16 family physicians in the team for many years now. We have units and beds. We have palliative home care and outpatient clinics. So all of this was still active during the whole of the pandemic, except for our beds in Sacré-Cœur that we've lost for the acute care, but we had to manage around and things were a bit hectic on that hand too. We also had a shortage of staff during the pandemic because many reassignments and with all of our doctors. So we did work a lot, as you said, Anne Boyle, earlier on. Next. So what we wanted, when it started in March, we saw that, as you said, not so many physicians and staff is used with palliative care. So we really wanted to share our knowledge and try and help as much as we could people to give adequate comfort care with patients with COVID-19 who would require this kind of care. So we also had the help of nurses to complete our first short guide for nurses it's all in French. I'm going to put down the links they're not at the end right now, but they're going to be on the Pallium website. So I have a drive where you can have the different documents, a lot of them are numbers. So even though you don't speak English, you could probably understand most of it. And if anyone would like to translate it, then we could try and do that in the next few months if things are still cooling off. And I put down my email, so as if you want to write me, it's something we can exchange about. Next. So I compare with Montreal protocols, most of the different CIUS have produced their guides depending on their particular setting, but globally we're pretty much in the same direction, and we did quite about the same thing. Because we know each other for a long time, so we worked all together with the same, pretty much the same protocols. Next. So this is one of the documents that we have produced, which is more complete with all details. But next, we also have all sorts of one-pagers and guides for the doctors, and next also for the nurses, to try and help people who've never have had really contact with palliative care, give adequate care in a situation where you don't have time to read extensively or to try and learn. So it really had to go like 1, 2, 3 and go. So you could go next. So the goals of our guides when we made them was sort of a guide for dummies or a no-brainer. Of course, it's not that anyone is a dummy, but since not a lot of people had done palliative care, we really wanted it to be something you don't have to think about, and it's also secure. So we had one concentration as much as possible, and it was equivalent between opiates, the morphine or the hydromorphone concentrations that you'll see later, they're equivalent. So if there was a shortage of one meds, or if there was an error, a mistake between the two type of bags, then it would be a problem, except for like a severe allergy. But other than that, it would be equivalent. Also, the security of the caregiver, the swiftness, and concern with medications shortage that we really had in Quebec. It came very close to be a catastrophe on that side. Next. So the highlights of our protocol, what we used a lot was continuous subcutaneous perfusions with one concentration for each site. Since people were not used with using those perfusions, we wanted to reduce the risks of errors as much as possible. And we would control the symptoms with the rate of the perfusion. Talking with Anne Boyle, I saw that in Ontario, what usually do, well, in McMaster at least, they have really, really low perfusion rates, but we do use a bit more. So we were not afraid to adjust the rates to go to a little higher rates. You're going to see later on. The IV pumps, we really had to, you know, give a lot of training on that because not so many nurses are familiar, especially in the long-term care facilities. There was also the intermittent analgesia for situations where the perfusions were impossible, the other symptoms management, and also technical and logistical issues. I'm sorry, English is not my first language, so sometimes I rough it out with some words. So what have we learned with using the protocols? Instead of describing precise case, since Anne did describe pretty clear cases which resembled a lot of what we had, I decided to sort of amalgate learnings from cases seen. Roughly talking to my colleagues, because I've been like for 20 years in the same center, so I know a lot of family physicians there. So I've talked to most of my colleagues, accounting for about 700 cases and 280 deaths to have an idea. Of course, this is not, you know, evidence-based. It's not been calculated and written down precisely. It's with discussions, but, you know, it all goes in the same direction. So I think we can derive pretty much things from there. And in the short-term care, I was many weeks in Sacré-Cœur Hospital with our regular palliative patients because, yes, palliative patients were still there during the COVID, but also COVID-19 palliative patients. And I've talked to palliative care colleagues, emergency and intensive care colleagues. So I think I have been around our situation. I have quite a good portrait of the situation. So next. So we have in the little, what we've learned actually, it was about the doses, the perfusions concentration, the shortest, okay, it's because it's just a little different from the presentation. So those were the titles actually. So the doses, which was the perfusion concentrations and so. And in the vast majority of patients, I would say almost all end-of-life care patients in all long-term care facilities, the usual doses used in regular non-COVID patient would work fine. We expected higher doses in non-opiates naive patients, which was the case in your second patient, Anne, which is comparable to what we usually have in palliative non-COVID palliative care. But aside of the patients being non-naive, we did not really have issues to patients needing very, very, very high dosage of medications. Next. So what we did, we had planned on doses to have something that would last long, but there was the shortage of medications that was really worrying the pharmacists in our centers. So after reviewing our first documents where we had the higher concentration, it was withdrawn, and we were sort of required to use a low concentration medication for the people into the long-term care facilities. So what was planned was to use the low concentration, the one in green, in the long-term care facilities, and the one in orange, the medium concentration, in the short-term care hospitals. Also, it would be used in a 50 milliliter bag, so we would lose less medications if, unfortunately, the patient would go when the bag was not totally used. So you can go next. So I'm not going to go over those numbers. It's just to show you, when you're going to have access to the documents, to show you what it represents as of rates. We would start around 4 milliliters an hour, depending on the patient. I would sometimes start much lower than that. I've started at 2 cc's an hour. I've even started one patient at 1 cc an hour, and after a few days he was at 3, and it was very comfortable till the end. So it really depends on different situation, but that gives roughly an idea of the low concentration. And we have on the next slide also the average, the medium concentration, which is the double of the other one. So you just double the numbers and you get it. So for some very frail patient, 4 cc's an hour would be a bit too much. So we would start lower than that and just adjust. The important thing is that it's to start slow and go slow most of times. But in the COVID situation, we would just not go too slow, of course. But we would start low depending on the symptoms, because most of times it would be working. So you can go next. So if we look at the reality test, the low concentration, even though we were worried, was working for most cases. So in most situations, we would have a 4 or 5 cc's an hour. This is our usual subcutaneous perfusions, which work a bit differently normally, but we do use all the time 4 or 5 cc's an hour, and it works very well. So with the low concentration, it was easy to reach 8 cc's an hour, and we were really trying not to go over 10 cc's an hour. So with the low concentration, even though it would work, with a patient which is not naive, then we would be struggling and a bit worried about the rate of the perfusion. So we did not really like to use it. And also, when you get a rate of 8 to 10 cc's an hour, of course, the 100 milliliter bag will not last very long. We do prepare the bags on the wards compared to Anne Boyle's situation, but still, the nurses were not really having time to prepare them as much as would be needed with the low concentration. So we really did prefer the medium concentration, which was used widely and which worked in most cases. Rate increase depending on symptom control, mostly in the beginning, would be helping, and a lot of patients did, continue on when we found a good rate, if there was no distress, they would go peacefully on a pretty much constant rate over the few days they would have the evolution. Next. So with the reality test, we are planning to withdraw the low concentration on our future update because we think it's too low, and we just hope that the issues with the shortage of medication will be past us, so we can probably use the medium concentration in most cases. There's also the high concentration that can use very low rate, longer duration of bag. But one thing that we found was important is for security issues, especially when you are in a facility where they're not used to use perfusion for palliative care or for care at all. It would be important to have one concentration to minimize the risks of having mistakes in preparation or mistakes in the bag that's put, because of course, if you double the concentration and keep the same rate, there's going to be some issues with the patient. So you can go next. So we also had some things with other symptom control, which in the next slide, Rales and secretion that we feared a lot at the beginning. We found that with COVID, and it's probably the case also you had, Anne, that most patients were fairly or even severely dehydrated. We had a lot of people in acute care hospitals. People came very, very dehydrated and with hypernatremia. So there were, in many, many situations, few or no Rales. So we did not have the Rales as much as we expected, though in some people, of course, there was. We used glycopyrrolate widely because there was a shortage of scopolamine in the same time, but we did keep some scopolamine for some cases. Usually the efficacy of both are about the same. The problem with the glycopyrrolate is its volume, because it's more volume for the same kind of dose. So in some cases, we did use scopolamine and glycopyrrolate, and then we used also furosemide that we use subcutaneously. Normally, we don't have an issue getting it to the room with patients, so we usually give them in 2 sites in 3 times. But then we modified it for COVID, so people would have to go less frequently into the room. And if we had IV access, you can give 80 milligrams over a 2-minute period directly, not needing to have a perfuser. So that could also be used. And of course, a urine catheter would be very important in those cases. The respiratory distress protocols were actually just about the same as we usually use. In many cases of patients, what we've seen is the patient was okay in the morning, even talking and eating, and unfortunately was dead in the evening. So things came quite fast in a lot of cases. So the agony, it was really short transition to that, where we didn't have much time to give medication, and there was sometimes not so many symptoms and not so many distress. But when there was, the usual protocols were given, and as I've talked to my colleagues and as I've seen myself, in most cases, our usual protocols were doing well. Those are like parts of our slides. It's in French. I didn't have time to translate. Naïf is naive. So those are the usual doses for naive patient, or usually if people have higher doses, then we adjust depending on the dose that's regularly received. So you can go next. We also had the technical issues, as Anne has spoken earlier. So the lack of staff was a very big problem. The ratios in long-term care facilities is not for acute care, that's for certain, and that will have to be revised. Providing adequate care was a challenge, just hydrating people, and just as you were saying, the human and the touch, the time to touch was unfortunately not very available, and that was a big problem. And there was also the situation that if you would go in and touch in the shortage of staff that we had and you catch it, then you could not care for the other patients after. So we really had to struggle with this feeling of not being able to do adequate care, which was a big issue, and it still is. We still have to struggle with those feelings. The continuous perfusion gives always a baseline comfort care. It's not always perfect, but it's better than not receiving a Q4 hours meds. I've been in long-term care facilities like at 5 in the afternoon where the patients unfortunately did not have received them at Q4 hour medication since 5 in the morning. So of course, when I was coming there, the patient was not comfortable at all. So at least with a continuous perfusion, you do have a baseline, even though it's not perfectly adjusted, you do have something at all times. And it also reduces the need to see patient, come out of the room, prepare meds, re-put your protective equipment, give meds, write it down in files, repeat it for hours. So all those things were helping a lot. So next, the learning skills, new skills in a crisis situation, though was hard, mostly for the nurses, it was a challenge. And people were afraid of that. But what we observe actually and learn is that after a few minutes of stress, even though nurses who had never since school used IV pumps really saw how useful were the perfusion, and it was adopted quite fast. So you really sort of needed to have a champion nurse that would just convert her colleagues, and then you would really have it. So we had hope. We would have hoped actually that we could have gone there and teach for the perfusions earlier, but at least we were able to do so for some patients. And it was a great benefit that we've seen also to see one, do one, teach one. So to really get into the wards and show the nurses from A to Z what to do. Just not tell them in a paper and follow this paper, but really go with them and show was really helpful. So one thing for the doctors, we do have to learn to be independent for those perfusions or those kind of care, so we can show the nurses what to do. I was fortunate enough to have done that a lot of times in home care settings or different settings. So I was very familiar with all the pumps, all the preparation, so I could do that. And I really found that it served me well. So I really think this is something we could learn and do for the future, just to learn something that we do not usually do. So next, and the hardware I would call, as you were talking, well, most of our long-term care facilities did not have IV pumps to be used for the continuous subcutaneous perfusion. So we really had to move the pumps from the short-term to the long-term. And just relearn to use the drops for the hydration IV, so you don't need to use the pump because it's elsewhere for better purposes. Training for pumps in long-term care facilities was also a challenge, so it's important to plan that ahead for the future. Next. The long tubing, as you were also talking, could be used to put IV pumps outside of the room. This is the reason why we were talking earlier about having a long tube, because if you would put the pump outside of the room, then you would not have to go into the room to change the pump. But then you have to, there's a compliance of the tubing. Of course, it's something that's it's a flexible tubing. So it has a compliance. So the longer it is, the lower the rate is going to be at the end. So if you have a very, very low rate, then what's going to come out at the end is not going to be very big enough. But since we're controlling with the symptoms that we can observe, and if we have the pump outside of the room, we can just increase the rate. This was not such of a problem. But we had a lot of problems just getting those long tubings at first, but we did use it a couple of times, and it worked well. It's also, there's some issues with the number of cc's in the tubing because you don't want to lose the medications. At some point, I've even injected we had 40 cc's in the tubing. So I've even injected at the end 40 cc's of saline into my bag. So I would pass on the medication in the tubing, but I was there to watch when those 40 cc's would end, because of course you don't want it to be ending and start giving the saline to your patient. You want to give him the medication. So you have to be like very conscious of those issues. The concentration of the medication in the bag, no matter the length of the tubing, you have to be taken into consideration that if you change the concentration, it's not going to change instantly into the tubing. So you have to take care of that if you do decide to change the concentration. But in a crisis situation, we really do advise not to change the concentration and to adjust it by rate. Otherwise, the calculation and the checkings are very hard to do. Next. So as for take-home message, one I've not written, but I found really important, as you said, Anne, the whole human crisis that we had and struggling with patients not receiving adequate palliative care when they were at the end of their life was really something we have struggled with. And it's really something we have to take care of if this is to come back again, because this is not something we can handle so many times. And I'm really sorry about that. And if we go on the more medical and easy to speak things, well, the COVID-19 palliative care, the doses seems to be very comparable to what we usually use in palliative care management. So we did not have to really change our usual teaching. The settings have to be adapted to the context, and the security always have to be kept in mind at all times, because time flies and it goes very fast. So we have to think ahead of all those problems, especially as I was talking about, changing the concentration. This is something when we made the documents that we've foreseen that it would be a problem if we would change the concentration along the use of the perfusion. So this is something we put very clearly, not to change the concentration. So when you're just making things around, we have to try and think about everything, which we will not, but as much as we can. And also we do have to prepare, to better prepare for the next wave or for whichever other crisis we will have in the next, or I hope the most far away future. So that pretty much concludes this resume of the things.
Thank you so much, Dr. Anne BH. One of the things I noted when both of you were speaking, clearly your dedication to this situation. You both speak so fluidly and so connected to the first person. I commend you both. It just really came through loud and clear. I'm going to moderate the questions now. We have about 10 minutes. And I'm going to start with the ones for Anne BH, because your slides have just been up and they all seem to nest well together, Dr. Anne BH. Just a quick one there from Aileen. Were the infusions you referring to, were they sub-Q or IV? You're on mute there, Dr. Anne BH.
Mute myself, it's silent around, so I won't have that problem. No, we mainly use sub-Q, actually pretty much always sub-Q, because we don't have, especially in the long-term care facilities, having access to an IV was
right.
Not an issue in most cases, I would say. So we would use subcutaneous. Even though patients sometimes with cachexia was a problem, we always tried and find somewhere where we could go, and it would work in most cases. So we very rarely use IV.
Okay, thank you. And then another question, could someone was asking, could sub-Q boluses Q1 hour or Q2 rather than continuous fusions have been used, do you think? Just for the purposes, as you see in the questionnaire, of, you know, tethering to the pump and et cetera, et cetera. What are your thoughts on that?
Well, we did use them because there were not pumps everywhere, of course. But the thing is, every time the nurses would have to go and give an injection, she would have to look through the file, see what dose she has to give. She has to open the cabinet, prepare the injection, write it down, have it verified by a colleague, then get dressed, get inside, and so and so. So this was very long. And having a nurse with 50, 60 patients, that was totally impossible. This is one of the reasons why we went with the infusions. And honestly, with the pumps we have now, the noises and the lights from it is not an issue. And with the subcutaneous infusions, we don't have, we don't lose the vein, of course. And if it would infiltrate, it would not be a problem because there would not be danger from it. So this is also another reason why we mostly use sub-Q.
And so, I mean, the next question fits with that. Would you recommend, all things considered, just starting with infusions versus Q4 to 6 medications, as Krista's asking, or did you change anything in COVID that way, or?
Well, actually, I'm quite biased because I really do like continuous perfusions because I find that they're more continuous, that we don't have peaks increase when we go with the medication. So I really, from the start, use them a lot. Of course, we usually personalize them at the situation of the patient differently than with the COVID situation, but we do use them a lot. But there's no, there's no definite reason why we should use one or over the other. It really depends on the situation, but it's never a bad thing to use the 2, 4, whatever, 6 hours medication if the patient's comfortable. The end point is having the patient comfortable.
Fair enough. And did you see any issues with equipment or pump allocations? Did your organization purchase more pumps? Like, did you have to do anything? Yeah.
Well, we did. Actually, at first, maybe shouldn't say that, but at first I said that if I would see any hydration IV Sacré-Cœur, I would just take the pump and bring it to the long-term care facility myself because we needed them there. So, but it was not from there. It's just a little joke, but still, they did quite fast, not fast enough, of course, because things happened very, very fast. It started on the 22nd of March in our facility. So things were we were really ahead of the things. So it took a little time, but we really had good collaboration and they were already buying new pumps. So the old pumps were fastly transferred in the different facilities, having a concern to bring all the same brand or same model of pump in the same facility. So the nurses would have to learn one model.
Gotcha. All right, because someone asked that very question. So it looks like you work through different pump technology and long-term care and availability, like you worked that through. I think Anne might have frozen there on us.
Okay, I mean, I know 6 type of pumps now. I'll close my video maybe because it's a bit unstable right now, but yes, so we do know them, but at least in each facility, we had only one type of pump. So when a nurse would learn it, she would be fine for the rest.
Okay, thank goodness. Any pushback, a question is, from long-term care homes on policy and willingness to implement these various treatments?
Actually, we had, there were worries mostly from the authorities that learning into a crisis situation was a problem for the nurses. But what happened in reality, we find is they were eager to live their life and how the patients
so
we had to be on the board.
We're not hearing you, Anne. I'm sorry to say. I'm gonna
I'm gonna close my camera. I'm gonna close my camera.
Okay. Okay. So I think we got part of that. We'll move on. And some questions for Anne Boyle. The wine swabs, Anne, was there pushback from the hospital about you doing wine swabs, or?
Well, I did that not into COVID, but I have done wine swabs or beer swabs in the past. And yes, it can bring some happiness to a lot of patients, and we do that too.
That question was directed to Anne Boyle. So,
oh,
Anne,
sorry.
That's okay. What did you find at St. Joe's, Anne Boyle?
No pushback at all. Good, you know, Catholic Irish drinking heritage here in St. Joe's. So
thank goodness we have a circle of trust here on our website.
Yes, very good that we have a circle of trust. No, actually, our hospital is very kind. We have an electronic medical record, and they actually have built into the medical record an order that a patient may have an alcoholic beverage if approved by the physician and provided by the family.
Okay.
So it is not there was not pushback, thankfully.
Okay. There's a couple of just thanks for having some of this in French and BH. So that was deeply appreciated by some of our participants. Then there's a comment from Marie Christine for us to read. And Boyle, I want to ask you, because earlier on there's a question about DEX doses. What DEX dose did you use? And in centers that have hydrocortisone, could they use that? Or what do you have to say about that?
Yeah, so I think that the literature that is emerging with COVID is that DEX may actually be beneficial for management of COVID itself. And so what I was saying is that while we didn't use it in those cases, looking back now, I probably would have actually given, especially with the severe dyspnea, I probably would have used it. And orally, if people are able to swallow, obviously if people can swallow, use that mechanism, but sub-Q or IV if they had access, certainly sub-Q if they didn't. I'd use DEX if we had DEX. DEX may be in shortage, so it may be like opioids where you're looking at a class effect going forward if DEX becomes a shortage. And I've had glio patients recently who have said they're actually having difficulty getting DEX from community pharmacies because of this emerging literature around DEX benefit in COVID.
Thanks, Anne. Back to Dr. Anne BH. I'm just mindful of the time. There's a question from Terry. With the continuous infusions, what's a typical volume of fluid given over the course of a day? Oh, you're on mute there again.
Yeah, I'm muting myself again. So what we usually do, you know, is 4 or 5 cc's an hour, so times 24. We usually pass our 100 cc bag over a day. That this is non-COVID situations, and it pretty much was around that what we had during the pandemic also, and it works fine. We've been doing that I've been doing that myself for 20 years, and I know that we're doing it before. Gotcha.
Thank you. There's a comment here from Cynthia. She said, just a thought in thinking of the future with possible second wave epi lines or individualized pain pump infusions. Wondering if that would be available in your facilities, either one of you.
I'm not certain what you mean, individualized pain infusion pumps. You mean like the CAD pump or the pumps that we usually use for an outpatients? Or?
Yeah, I think the question from Cynthia is just if this were to ramp up and we would need more of both what the two of you have been through, using more pumps than ever, particularly for different reasons, and we've used them before with different drugs. Will there be difficulty, you think, ramping up to this in the second wave?
Whatever pump I have, I will use if needed. So, and for the subcutaneous, it's not a problem at all. So I think any infusion pump could be working on that side. I've seen some techs working with the operating room pumps, and this is something we could have used too. It was a model that was not in the long-term care facilities, but it was they were using intensive care a lot.
Okay, thank you. And last question we'll put to Anne Boyle. I'm going to do a 2-for-1 here, Anne. You might comment yourself on your capacity for more pumps. And then a question from Marianne. How did you handle the family visits with members? Did they provide care? Did they wear PPE?
So it varied over time depending on what the rules and regulations and the nurse managers allowed in different units. But if patients were visiting and had PPE and were able to provide care and chose to do that, then that was allowed. It's very much been patient and family guided here at our hospital. They limit numbers, obviously, and PPE conservation was varying issues at various times. So it's really had to fluctuate. And I think that's really what the message in COVID is, you know, pivot, fluctuate, change, bend. This is a dance, and we have to learn all the different steps. And it changes, the dance moves change all the time.
Thank you so much to Dr. Ann B. and Dr. Ann BH. I just took notes. It was incredible, the amount of information that you shared, and to our participants for asking very granular, practical questions, which I think this webinar has highlighted. It's just down in the weeds, what do we do? Thank you both so much. I will turn back over to Jeff Moat from Pallium Canada.
Great, thanks, Denise. Listen, on behalf of Pallium Canada, I want to thank our esteemed panelist and moderator for the time that they've invested in making this webinar happen, and for the rich dialogue that has ensued. We're very appreciative of the content that you've shared with us, the time that you put into preparing the slides. It was fantastic, and great questions from the panelists as well. A big thank you to all of you out there for taking time out of your schedule to attend this webinar. I really hope everyone's found it of value. I think based on the questions that we've received, I think that is certainly the case. One last plug for the Palliative Care Exchange, cpcexchange.ca. Please visit that website. Let's keep this dialogue going. There's a lot more to discuss. That's the forum to do that. Following the conclusion of this meeting, you'll be sent an email with a link to provide feedback on today's session. I'd encourage all of you to share your feedback with us. The only way we're going to get better with these is if we hear from you. So please fill that out. We do appreciate that. I wish everyone a good rest of your day and take good care. We'll see you on the next webinar. Bye-bye.